Good morning and welcome to the JASN podcast, where we highlight an interesting recent paper from the journal. I'm Dr. Alessia Fornoni, professor of medicine at the University of Miami and a deputy editor of the journal. I'm joined today by Dr. Lilach Lerman from the Division of Nephrology and Hypertension at the Mayo Clinic in Rochester to discuss her paper entitled Renovascular Disease and Mitochondrial Dysfunction in Human Mesenchymal Cells, which appeared recently in JASN. Dr. Lerman, please introduce yourself and tell us a little about your background.
Thank you very much, Dr. Fornoni. It's really a pleasure being here to discuss our study with the JASN readership. I am, as you mentioned, Lilach Lerman. I'm a professor of medicine and professor of physiology at the Mayo Clinic Graduate School of Medicine. I'm also the director of the Renovascular Disease and Research Laboratory. I've been involved in translational research for a few decades now, and in particular interest on renovascular disease.
Great, Dr. Lerman. So let me get started. Renovascular disease is clearly an area of unmet medical needs that contribute to kidney failure, particularly in the elderly population. What are the current available interventions and their limitations?
Well, this is actually a very timely question. In actual fact, given the causal relationship between renal artery stenosis and kidney dysfunction and development of renovascular hypertension, it has been hoped for many years that revascularization of the stenotic renal artery, which is also called percutaneous transluminal renal angioplasty or PTRA, would be able to restore the function of the stenotic and ischemic kidney. Unfortunately, as it turned out, a number of clinical trials, especially the most recent CORAL trial that was published in 2014, showed that the improvement of renal function and blood pressure control are not necessarily achieved after restoration of the patency of the renal artery. This observation has led to a precipitous fall in the use of these procedures in patients. Currently, the treatment options focus on medical therapy to control blood pressure and atherosclerotic disease. For example, with the use of ACE inhibitor, ARBs, and statins. Nevertheless, studies have shown that select patients might benefit from PTRA, from revascularization of the stenotic renal artery. So that one perhaps unfortunate outcome of an indiscriminate fall in the performance of revascularization is that we seem to see more patients who develop kidney injury distal to renal artery stenosis. Hopefully in the future, we might find methods that would predict which patients might benefit from revascularization so that we can select them more carefully and focus only on those patients who can benefit from the procedure.
Very encouraging. I totally agree with you. We need a better patient stratification in this space. So let me go to some questions related specifically to your contribution. You found a quite different reparative potency in mesenchymal stem cell isolated from healthy control versus those isolated from patients with renovascular disease when you actually injected both of these cells into mice with renal artery stenosis. What do you think is responsible for such a different transcriptomic signature between these two types of MSCs?
Well, we know that patients with renovascular disease are actually subjected to several types of risks. They have chronic kidney disease, for example, circulating uremic factors in some instances. They have renovascular hypertension, and they also often have atherogenic factors that are either circulating or inside the kidney tissue. For example, high cholesterol levels or inflammatory mediators. All of these factors may dysregulate the mRNA and microRNA cargo, as well as mitochondrial function of those mesenchymal stem cells that are obtained from patients with renovascular disease. So they have a number of mechanisms that can impair the function of mesenchymal stem cells. They probably impose their effects by epigenetic mechanisms. For example, we have previously found that the presence of obesity in human subjects alters the 5-HMC profile of mitochondria-related genes. This in turn may mediate obesity-driven dysfunction of human adipose-derived MSC. Those changes also included nuclear encoded mitochondrial genes that are involved in ATP production, redox activity, cell proliferation, migration, as well as fatty acid metabolism. So we know that the presence of cardiovascular risk factors of various diseases can alter the epigenetic landscape of mesenchymal stem cells. It would be interesting to determine, I believe, whether similar mechanisms are also activated in renovascular disease. But this would require additional studies of looking at epigenetic mechanisms more specifically.
Very interesting. And do you think that mesenchymal stem cell isolated from a compartment different than the adipose tissue would result in a similar molecular signature?
This is a good question. Generally speaking, mesenchymal stem cells that are isolated from different compartments are thought to bear similar characteristics. However, their properties, as well as their therapeutic effects, might vary by their source, so that they might differ functionally. For example, mesenchymal stem cells from bone marrow have been shown to have high differentiation ability and shorter population doubling time compared to adipose tissue-derived mesenchymal stem cells. On the other hand, umbilical cord mesenchymal stem cells, or WJ mesenchymal stem cells, show the highest proliferation activity. Yet, bone marrow-derived stem cells do enter senescence after passage 4, while some adipose tissue mesenchymal stem cells don't show senescence up to passage 7. So they do have some differences. But one important function of MSCs is actually their immunomodulatory ability. And the vast majority of currently published data suggests that there are no significant difference in the immunomodulatory potential of mesenchymal stem cells that are derived from alternative sources. Although the results have varied greatly because of differences in experimental protocols or the characteristics of the MSC populations. So overall, there might be some differences among MSCs based on their source, but I do believe that most types would be effective, at least to some degree. We have chosen to focus on adipose tissue-derived mesenchymal stem cells because they are relatively easily accessible with minimal invasiveness. So they are suitable for autologous delivery.
Very fascinating. So do you believe that actually the beneficial effect you observe in the MSC transplanted models you studied of renovascular disease, is it linked to actually the replacement of renal resident cells or renal arterial cells, or is it linked to actually vesicle release, the carrying paracrine factor, or that could actually endocrine factor that could influence the function of the kidney?
Well, it is now widely accepted that most of the beneficial effects of transplanted MSCs are derived from paracrine mechanisms. These include the release of growth factors, anti-inflammatory factors, as well as extracellular vesicles. This is absolutely correct. Initially, early studies have implied that stem cells differentiate into epithelial cells, but subsequent lineage analysis refuted this notion. So mostly it is paracrine function. It is possible that extracellular vesicles do mediate some of the function of the mesenchymal stem cells. In fact, we found that if you inject the extracellular vesicles directly, you can replicate some of the benefits of MSC delivery. However, it is likely that their residence time and their survival time in the tissue is shorter than MSCs. Although the MSCs do not necessarily replace renal resident cells, they might still integrate in the interstitium and they might proliferate, so they may survive for a few days before their demise by macrophages or other mechanisms. So I think that a lot of the mechanisms of the effects of the benefits of transplanted MSCs is related to paracrine mechanisms, including extracellular vesicles, rather than replacement of renal resident cells.
Very nice. And I was really impressed to see that you have really clearly identified MIR378H as the key mitochondrial microRNA upregulated in renovascular disease in the era where mitochondrial function and kidney disease are heavily linked. I found this very intriguing. What do you think is the mechanism linking this MIR378H to the observed finding? And do you believe that there is a therapeutic opportunity here to develop MIR378 inhibitor for the treatment of renovascular disease in affected patients?
This is a great point. We did find that MIR378 was about tenfold upregulated in MSCs from patients with renovascular disease compared to healthy volunteers. The its 378 family members participate in important processes, including aging and cancer biology, and they also modulate angiogenesis. Moreover, maybe more specifically to our study, the miR78 targets important key genes that are involved in cell proliferation as well as in mitochondrial function. These include, for instance, apoptosis, lipid metabolism, and metabolic processes. We found, interestingly, that inhibition of miR378 restored the expression of its mitochondrial gene targets. It also attenuated mitochondrial impairment of human RVD MSCs in vitro, as well as in vivo. It restored their ability to repair murine post-stenotic kidneys. Therefore, our observations implicate miR378 in the mitochondrial damage and maladaptive kidney repair that is achieved by human RVD MSCs. However, regarding the potential of miR378 as a therapeutic target, I believe that we need additional studies to determine whether its expression is altered in other cell types in patients with renovascular disease. Furthermore, it does have other activities. For example, miR378 mediates bone metabolism, it influences bone development, and so that its inhibition promotes bone formation and stimulate fracture healing. It also alters the MSC osteogenic differentiation, which we did not compare in our studies. However, we need additional studies to ensure that if we inhibit it, then its widespread inhibition would not induce, for example, ectopic calcifications. Therefore, while I would not rule it out, the safety of this approach needs to be further evaluated, but I think it could be a very novel new therapeutic strategy.
Oh, that's really amazing. And let me ask you one final question. I've seen that autologous adipose-derived stromal vascular fraction cells were recently shown to improve CKD of unknown origin by reducing resistive indexes. Can you speculate on the presumed mechanism and how these findings relate to your findings?
Of course, in fact, the adipose tissue-derived mesenchymal stem cells do have perivascular origin, and they are derived from stromal vascular fraction of adipose tissue. So sometimes they're used synonymously, in fact. And there are several mechanisms by which adipose tissue-derived mesenchymal stem cells or stromal vascular fraction cells may be able to reduce resistive indexes. And these include by affecting the intrarenal microvascular structure as well as function. In terms of structure, although we did not find them integrated within blood vessels, adipose tissue-derived MSCs increase microvascular density. This is achieved by paracrine mechanisms and by improving tubular health. It is known that crosstalk between renal tubular and endothelial cells maintains and sustains the renal microcirculation, so that an increase in renal microvascular volume may in turn decrease vascular resistance within the kidney. In terms of function, mesenchymal stem cells decrease both inflammation and oxidative stress. By this mechanism, they may improve microvascular endothelial function and vasodilation, and this in turn would likely lead to a fall in resistive index. Therefore, we believe that these cells employ several different mechanisms to improve vascular function and structure, which may lead to a fall in intrarenal resistive index.
Thank you, Dr. Lerman. This has been an amazing interview, and I really feel that you're opening the field to new potential therapies for patients affected by renovascular disease. And I'm sure the reader of the JASN would be excited to review your paper and get back to you with additional questions. I again appreciate your time, and I wish you a wonderful day.
Thank you very much, Dr. Fornoni. This was a pleasure, and I will welcome any additional questions.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.